And on that note about World Amyloidosis Day, it's the opportunity to truly thank our local communities. The response that we got from our local communities to help raise awareness and help us promote World Amyloidosis Day was absolutely phenomenal. To our local and national media, we thank you. For the fabulous people who posed with our World Amyloidosis Day banner, we thank you. As Jean-Christophe mentioned, we hit the top of the league with social media. It wasn't of me, it was of Mr. Colin Farrell. So, and just to let you know, I have laid claim to the banner that he held, and it's going to come and live with me. So thank you for that support. We are now delighted to introduce you to Professor Sinéad Murphy, Consultant Neurologist from Tallaght Hospital in Dublin, and her presentation is on ATTR amyloidosis and the autonomic nervous system. Professor Murphy.
Thanks very much, Rosaline, and thank you for the invitation to talk today. I'm delighted to be here. And so I'm interested in inherited neuropathies, of which obviously hATTR is one. And I've been asked to talk about the autonomic nervous system. So I figured that some people here wouldn't know a whole lot about the autonomic system, so I thought it'd be useful just to briefly touch on the anatomy and the functions of the autonomic nervous system, talk about the symptoms and how it affects people, talk about how we assess it in clinic, and talk about management of symptoms. So, broadly speaking, the nervous system can be divided into the central nervous system, which is the brain and spinal cord, and the rest is the peripheral nervous system. And the peripheral nervous system can be divided further into the somatic, which is your voluntary nervous system, and the autonomic, which takes care of all of the involuntary things that happen in your body all the time. So, the autonomic nervous system is further divided into the sympathetic, parasympathetic, and then some people also would include the enteric nervous system as part of the autonomic nervous system, and other people would consider that the enteric nervous system is an entirely separate piece of your nervous system, but I'm kind of agnostic, so I've put it in here. The sympathetic nervous system is what causes your fight or flight response. So if you're running away from someone, your heart rate and your blood pressure are supposed to go up. Your gut peristalsis stops because you don't want to be digesting your food. You want the blood to be going to your muscles to be able to run, and your pupils dilate so you can see better. The parasympathetic nervous system does more or less the exact opposite, so rest and digest. So if you think about how you feel after Christmas lunch, you just want to sit down, have a snooze. While your dinner is digested, your heart rate and your blood pressure go down, your pupils constrict, and you relax. And then the enteric nervous system takes care of the blood flow to and from the gut and secretion, absorption of digestive juices and so on. So all of this stuff is going on in everyone in this room all of the time, and you don't really have any control over any of it. So there are lots of causes of autonomic dysfunction, but hereditary transthyretin amyloidosis and wild-type transthyretin amyloidosis are two causes. In terms of ATTR, so autonomic symptoms are an early feature in hereditary transthyretin amyloidosis, and certainly anyone coming to clinic with a neuropathy who has autonomic symptoms, you always think, could it be amyloid? And the problem with the symptoms is that they're a lot of them are non-specific, and so often if you're not looking out for them, people don't really realize that they are an autonomic symptom. A lot of patients with amyloidosis obviously have cardiac and GI conditions and might be attending cardiologists and gastroenterologists, and if they complain of feeling faint, it might be considered to be a problem with the heart, but maybe it's not. Or if they complain of problems with digestion, it's considered to be part of their GI disease, which might not be known to be amyloidosis, of course. And it may not be recognised that a lot of those symptoms are actually due to autonomic dysfunction. The other thing is that a lot of drugs that people are on for amyloid worsen autonomic symptoms. So in particular, things like diuretics and blood pressure pills will make a lot of autonomic symptoms worse. And so I guess there's a constant battle between the cardiologists and the neurologists, on the one hand wanting to increase diuretics to help with the fluid, and on the other hand wanting to reduce the diuretics to help with the blood pressure. And if someone has significant autonomic neuropathy, that may limit therapeutic options for their heart failure, for example. Now, in terms of how we monitor the autonomic symptoms, as amyloidosis progresses, mobility often declines, and that's for lots of different reasons. But it makes assessment of autonomic function more difficult, because if someone can't stand up, it's difficult to assess a lot of the autonomic symptoms. And we do know that autonomic dysfunction impacts on quality of life and prognosis in patients with amyloidosis. So some of you will have heard of the THEOS registry. This is a registry of people with transthyretin amyloidosis. It includes people from the pre-symptomatic stage to very advanced disease. And they just looked at autonomic neuropathy at any point in time and found that over 40% of patients in the registry had autonomic symptoms, and 77% of those patients had autonomic symptoms by the time they were diagnosed. Now, often that's because the diagnosis is quite late. The graph on the right, the blue bars are people with hereditary forms, and the yellow bars are people with wild type. So you can see that for each of these separate autonomic symptoms, both wild type and hereditary amyloidosis patients get them, but less so for the wild type than with hereditary. The first disease, so first amyloid symptom to the first autonomic symptom, is less than 3.5 years for hereditary, and it's almost 10 years for wild type amyloidosis. So it's a later manifestation in wild type. In my own clinic, 63% of patients with hereditary transthyretin amyloidosis had symptomatic autonomic dysfunction by the time of their first visit with me. So there's a very long list of autonomic symptoms. I guess a common one is orthostatic hypotension. So when you stand up from sitting or lying, you might feel a bit woozy or lightheaded or dizzy, and you might go so far as to faint. People get coat hanger pain, which is pain in the distribution of the coat hanger, and that's due to a drop in blood pressure. So when you stand up, your blood pressure really needs to go up to push blood up to your head, but if that doesn't happen, then you feel faint. If you have autonomic denervation of the heart, you get exercise intolerance. So when you go to exercise, your heart rate should increase. But if you have autonomic failure, then your heart rate can't increase, and so you can't exercise. People may get palpitations and cardiac conduction defects, not necessarily due to cardiac infiltration, but due to the cardiac autonomic denervation. Genitourinary autonomic dysfunction is very common, so sexual dysfunction is something that is not asked about enough. But for men, I think we're pretty good at asking about erectile dysfunction, but we're very bad, I include myself in that, in asking women about sexual dysfunction. But that's very common in people with amyloidosis. And urinary symptoms ranging from hesitancy, so that's difficulty getting started, to not knowing when your bladder is full, to going into retention, so not being able to empty the bladder, incontinence, getting up at night to go to the toilet, and bladder infections. In terms of gastrointestinal symptoms, I think the most common thing is probably diarrhea, and that can be very difficult. But you can also have constipation or alternating diarrhea constipation, nausea, vomiting, gastroparesis, which is where the food travels too slowly through the stomach, and that can cause a feeling of fullness after only a few bites of a meal, or feeling overly full after a small meal, and poor appetite. And all of those things can lead to weight loss and cachexia and malnutrition, which impacts on prognosis. Then sweating disturbance is common, impaired pupil reactivity, which causes difficulty transitioning from light to a dark environment. And for people that also have diabetes, the inability to recognize hypos is something that can happen with an autonomic neuropathy. So those sensations of feeling tremulous, palpitation, sweaty, that people often get with hypos may not happen because the autonomic system isn't working. So there are a few things we do in clinic. So lying and standing blood pressure and heart rate is very straightforward, very simple. Any doctor or nurse can do it. often it's not done properly because you're supposed to have the patient lying flat for 5 minutes before you check the blood pressure. And then you stand them, check the blood pressure in the first minute, and then check it after 3 minutes of standing. And if the blood pressure is going down, then you keep on checking the blood pressure until it levels off. But most people in clinic really don't have time to do that. So it's often not done properly. A systolic drop of 20, diastolic drop of 10, or an overall systolic blood pressure less than 90 all would fit into orthostatic hypotension. One problem with amyloidosis is a lot of patients have atrial fibrillation, and that means that measurement of blood pressure is often not very accurate because you have beat-to-beat variation in blood pressure. And that's particularly the case with automated blood pressure monitors. And one problem in clinic is often that I know that patients tend not to drink or eat much in the morning of their clinic appointment with me because of the bladder and bowel dysfunction. And that will, of course, mean that their blood pressure is worse when they come to clinic. The other thing that we do in the clinic is look at pupillary function. So we shine a light in your eyes and look at how the pupils constrict, looking from far away to close up. And in autonomic dysfunction, the pupil responses are often not normal. We know that in people with diabetic autonomic neuropathy, the pupil response is one of the earliest signs of autonomic involvement. So pupil abnormality is very common in amyloidosis. It may be a poor response to light, it may be a poor dilation after you remove the light, and it may be a slow response to accommodation. You can sometimes get amyloid deposits in the eye causing this kind of scalloped appearance of the iris, and if that's there, then you can't depend on pupil responses. But other than that, it's a pretty good sign of autonomic involvement in the clinic. So in the neurophysiology department, this is Mike Alexander, who's our neurophysiologist in Tallaght. We do some standard neurophysiological assessment of autonomic function. So anyone who's been to my clinic probably will have had this done. So we look at R-to-R interval testing. So this takes advantage of the fact that when you breathe in, your heart rate increases, and when you breathe out, your heart rate decreases. And you can measure the time interval between those, and that's called the R-to-R interval. So the first test is heart response to posture. So you go from sitting to standing. You check the RR interval at beat 15 and at beat 30 and take a ratio. It's very straightforward. On the left is a normal response, and on the right is someone with autonomic neuropathy with no response. Sorry, the clicker's a bit slow. Then we do heart rate variation with breathing. So normal breathing, that we just monitor the heart rate and blood pressure as you're sitting breathing normally, and then do 6 breaths per minute deep breathing. And we look at the R-to-R interval, from maximum to minimum, and get an average. And on the left is a normal kind of response, and on the right you can see a very blunted response in someone that has autonomic neuropathy. And then response to Valsalva. So to do this, you put a clip on your nose, blow into a syringe, your face goes red and you feel very uncomfortable. And on the left is a normal 4-phase response, which should happen. And on the right is someone with autonomic neuropathy where there's no response. Then the other thing we do is a sympathetic skin response, which is the ability of the skin to sweat with an electrical current. And on the left is a normal response, and on the right is someone with an autonomic neuropathy. So these are kind of objective tests that we do as standard in everyone with amyloidosis. There are lots of other things that we can do, including tilt tables. We can look at gastric emptying to look for gastroparesis, urodynamics and post-void bladder scan to look at bladder control, and anorectal manometry, depending on the symptoms that someone might have. So orthostatic hypotension is a very problematic symptom for people. There are a lot of lifestyle measures that can help. So I wouldn't recommend putting your bed on chairs, but elevating the head of the bed by 10 centimetres can be very helpful. So you just put a brick or a block underneath the top of the bed, or you can buy wedges that go underneath the mattress that tilt the mattress slightly, and that helps to get a degree of tolerance to the low blood pressure and also reduces the risk of supine hypertension, which sometimes isn't so much of a problem anyway in amyloidosis, but just in case it is. The other thing is when you're getting up, to get up in stages. So rather than just like rolling out of bed and going off, you sit up on the edge of the bed and you sit there for 2 minutes. You should wait for 2 minutes because that's how long it's going to take for blood pressure and heart rate to settle before you get up again. And when you're sitting there, you should be doing physical counter maneuvers. So, moving your legs about, squeezing your hands, and this helps to increase venous return to the heart, which pushes your blood pressure up to allow you to stand up. When you're standing, if you're going to be standing for a long time particularly, the blood pressure is liable to fall and cause you to be faint. So when you're standing, it's a good idea to tense your leg muscles. So you might be just wiggling your ankle or whatever, but you should be trying to move your legs when you're standing, and that will help keep the blood pressure up. So if you think about what we talked about with after a heavy meal, so that's a bad time to be thinking of doing exercise because the blood pressure and your heart rate are lower than normal anyway. So if you want to do exercise or something active, save that for some time other than after a heavy meal. Bed rest is a bad idea for people with amyloidosis because you get physical deconditioning, but your nervous system will also get deconditioned and you'll be reset at a lower blood pressure. And then when you try and get up after a few weeks of lying down, you're going to feel much worse. So as much as possible, try and be upright. Even if you're sick, try and sit rather than lie all the time. Try to be doing exercises in bed if you can. Hot baths and excessive alcohol cause peripheral vasodilation, so your blood vessels dilate. That's why you go a bit red. And when that happens, your central blood pressure drops. So that will worsen orthostatic hypotension. So if you want to have a few drinks, maybe do it last thing at night before you go to bed. And if you're having a hot bath, certainly make sure someone's there to help you out so you don't faint, and get straight into bed afterwards, maybe. And then in terms of the compression devices, if you're wearing compression stockings, they should be thigh length, not knee length, for the best effect. And abdominal bind, the problem with compression stockings is that they're kind of uncomfortable and a lot of people find them difficult to put on if you get them the right fit. So abdominal binders are much easier because you just stick them on. You can get inflatable ones that you wear and then it's only when you stand up that you inflate it. And you can get combinations where you have stockings plus an abdominal binder. And apparently you can get as much as 10 to 15 millimetres of mercury blood pressure rise from those. So they are quite useful, separate from any medication. Normally, for orthostatic hypotension, we would say increase in fluid and salt, but we don't advise that with amyloidosis because of the heart failure. And then in terms of pharmacological things, so most people are on diuretics. It's good to take those at night if possible, because then the blood pressure during the day might be better. Now that will be counterbalanced by needing to go to the toilet more at night, but it will help the blood pressure during the day. Midodrine, it elevates your blood pressure, and we often prescribe that, taking it 3 times a day. I would say take the first dose at least half an hour before you get up in the morning to give it time to take effect before you're getting up. And a lot of people take the last dose before they go to bed, but that's too late. You don't need high blood pressure when you're in bed. So take the last dose maybe around tea time and then have your 3 doses kind of closer together. You'll get a better effect from it. Some people use droxidopa, so that has a bit more centrally acting effect, which is good if you have an autonomic neuropathy. The only problem is it's not reimbursed in Ireland, so you will have to apply through the hardship scheme or something to get that funded or pay for it yourself. But that can be good for some people that don't tolerate midodrine or it doesn't work for them. And pyridostigmine, which we normally use in myasthenia gravis, actually does give a beneficial effect to blood pressure. So some people are on the combination of midodrine plus pyridostigmine, and that can help keep the blood pressure up. A few people are on fludrocortisone, but I don't usually prescribe it because it causes fluid retention, which isn't very helpful with heart failure. And then there's loads of drugs which will worsen orthostatic hypotension, so particularly alpha blockers, so that's for prostatic hypertrophy, tamsulosin and things like that. Antihypertensive diuretics, lots of antidepressants. So if possible, if you can get away with it, cutting back on those is helpful. But, there's a balance, obviously, with the heart failure. So then the GI symptoms are very troublesome. I think probably the most problematic is diarrhea. There are some lifestyle measures that you can do for this. So a low soluble fibre, low fat diet is much easier to digest and results in less stool bulk. So if you've got a lot of bowel movements during the day, changing your diet in that way might reduce the output. So low soluble fibres, things like white bread, white rice, white pasta, white fish, or white meat and fish. And if you're having vegetables, make sure that they're cooked till they're soft. So it's not like maybe a diet that we would consider healthy for someone else, but for someone with amyloid and diarrhea, that can be quite a good diet. Mashing or liquidizing food helps you digest it easier, so that's useful. And taking the nutritional supplements obviously can help to get the calories up. Eating small, frequent meals rather than 3 big meals a day is better. Avoiding eating too close to bedtime, because if you eat too close to bedtime and then you go and lie down, you'll get reflux and vomiting. Bowel training, so trying to go to the toilet at the same time every day, even if you don't feel you need to go, just maybe half an hour after breakfast is a good time for the bowels. Sit, try and do it, and do it every day. Try and get into the habit of training yourself. There are things for incontinence, anal plugs. Never thought I'd be saying that on a stage. Most people with incontinence will already be carrying things like a change of clothes, but, wet wipes, whatever, things like that, because incontinence happens. Nausea. So ondansetron or Zofran is good for nausea, and it has a side effect of constipation, so that can be quite a good drug to use for those symptoms. And there are a number of different drugs that help speed food going through the upper GI tract. So metoclopramide, erythromycin liquid, domperidone. So these can be taken before meals and can be quite helpful. And gastric pacemaker, which is like a heart pacemaker but for the stomach to keep things moving, can be done for people with autonomic neuropathy. Culpramin, which is peppermint extract for cramps, can be quite helpful. And then for diarrhea, a lot of people use a combination of Imodium and codeine. And some people get quite good relief from that. And we've had a few success stories with octreotide, which is a subcutaneous injection that you take 3 times a day, and that can be very helpful for slowing down the bowel. And then some of the drugs that we use for neuropathic pain may also slow things down. So they're quite good tips for diarrhea. Constipation is less of a problem, I would say, for most people. But if it is a problem, laxatives are kind of first line. There's a thing called a peristine irrigation system, which is this thing here, which is basically sort of like giving yourself an enema each day. And that's really effective for neurogenic constipation. Abdominal massage. And then there's various biofeedbacks and electrical stimulation therapies that can be used as well. These are usually through gastroenterology departments, if there's a good gastroenterologist who's interested in functional bowel disease. And then for totally refractory symptoms where none of this helps, sometimes a stoma is very helpful and can really make quality of life much better because it means you can get out and about. So then bladder symptoms, similar to the bowel symptoms, very troublesome. Bladder training is much the same idea as the bowel training, pelvic floor exercises. There are some physical manoeuvres. So men, I would suggest, should always sit down when going to the toilet. And apparently that's standard in Germany. I didn't know that. But yeah, so sit down when you go into the toilet. That helps the pressure in the abdomen, so it actually helps with flow. Also, the other reason it's good is that often people, when they're trying to empty the bladder, will strain, and that's giving yourself a Valsalva manoeuvre, and that often will drop your blood pressure if you have an autonomic neuropathy. And so a lot of people find that they feel faint when they go into the toilet, or do faint. That's called micturition syncope. And so sitting down helps avoid that and avoid straining. And often just double voiding. So after you've finished, just wait a few minutes and then try and go again. And you might squeeze out a bit more, and that'll give you a bit extra time before the next time you go to the toilet. There are some things that worsen symptoms like caffeine, alcohol, spicy food, so maybe avoid those. Duloxetine may help with stress incontinence type symptoms. For poor bladder compliance, this is like an overactive bladder kind of symptom. Botulinum toxin can be very useful, so that's when the urologists inject botulinum toxin into the bladder. And sacral and posterior tibial nerve stimulation can be used as well. In other people with overactive bladder, we would use anticholinergics, but I would avoid those in amyloid because they will worsen a lot of the autonomic symptoms. And then for people who have retention, self-intermittent catheterization is really helpful. So these are the catheters. They're disposable. They're very small. That little white strip at the bottom is 5 centimetres, so they're tiny. You carry them in your bag and you pop them in, empty the bladder, take it out and throw it away. You do that first thing in the morning, last thing at night, and a few times in between, and that is really good for urinary retention problems. So unfortunately, there's very little research on the sexual dysfunction in amyloidosis, in general, but particularly in amyloidosis. So there is there's a number of treatments for men, so Viagra and the like. I would say you have to be very careful with those in amyloidosis because they do drop the blood pressure. So anyone that has orthostatic hypotension, you shouldn't really use those. So any GPs who are prescribing Viagra should check your lying and standing blood pressure before they do so. Alprostadil is a prostaglandin, so this can be given via a gel that you insert into the urethra in the penis, or it can be given by a direct injection into the penis, Caveject, that's on this top picture, and that gives a fairly reliable erection within 10 to 20 minutes afterwards. You can drop the blood pressure, but not nearly as much as Viagra, so that can be a useful treatment for erectile dysfunction. And then a vacuum pump, which is a very basic piece of equipment, can be very effective. You can buy it on the internet, so no one needs to know about it. And so that can be quite useful. You just pump it up, stick a ring on it, take the ring off at the end. And there are lots of versions now of implantable prosthesis, which can be done by urologists. This is one version where you press a button and that fills the prosthesis and causes the erection. You press the button again and it goes away. But there are lots of other ones which are even less technical than that. For females, there is basically nothing in the literature. As I said, we're very bad at asking about it. Vaginal dryness is really common, so vaginal lubricants can be useful. Basically, that's the end of what you can find in the literature. There is some evidence that testosterone replacement can help postmenopausal sexual arousal disorder. So there may be a role for that in amyloidosis, but it hasn't been tested. But it might be something that's worth considering. And there are other things being trialled for sexual dysfunction post-spinal cord injury, like vibration therapy, which is what it sounds like, and other kind of electrical stimulation type treatments. But none of these have been tested in amyloidosis. In terms of general advice, I would say that patient support groups are really important for people with rare diseases because the doctor hasn't experienced personally your symptoms, but you might find that someone else in the patient group has, and they might have learned a trick or a tip that might help. So I think it's always worth chatting with other people with your disease about the symptoms that you have. With autonomic neuropathy, there are going to be better times in the day and worse times in the day. So if there is something particularly you want to get done in a day, I think it's important to plan that for a time of the day when you know that you're going to feel better, when your blood pressure is better, and not after a heavy meal at the end of the day when you're going to be wiped out. It is important to keep active because if you don't use it, you lose it, as they say, but not to overdo it at the same time. So I would say little and often to, whatever is comfortable. And there are a couple of good exercises. So exercising in the pool, walking in the water is very good because if your legs are weak, the water holds you up. It helps with venous return, the pressure of the water in your legs, and you don't heat up too much. So that's quite a good exercise. And also recumbent bicycle, because if you're lying back, your head isn't too high, so you don't need to push your blood pressure up too much. And the venous return from the exercising of the legs is quite good. So they're good forms of exercise for people that can do it. So in conclusion, autonomic neuropathy is really common in ATTR, both hereditary and wild type, but more common in hereditary. We know that it affects quality of life and prognosis. It's totally under-recognised. And I think, there are a lot of lifestyle measures that can really help your symptoms, and I think it's important to try those before going on to drugs because people are on enough drugs. But they can certainly make a difference. And I want to finish by saying that it needs a lot more research, particularly, management of the troublesome bowel and bladder stuff and sexual dysfunction, which are very under researched. And I'd like to finish by thanking Mary Riley, who first got me interested in amyloid when I worked with her a long time ago, Mike Alexander, who's the neurophysiologist in Tallaght, Mark, who led the Model of Care working group, and Emer, who we work closely together with our amyloid patients. So thanks very much.